listening to talks of other speakers, quite in detail, lymphomas. That's good. Young, energetic crowd, and really liked about it. Otherwise, when you go into in your careers ahead, it will be like, okay, lymphoma, Hodgkin's, ABVD, non-Hodgkin's, B or T, CHOP versus R-CHOP, over. This is the mind frame. So, but yeah, things are changing. A lot of new drugs are there. You have to be little bit overboard before you start the treatment of any patient. Any pre-notions, whether it can be improved. We have to go from those B-cell lymphomas when the cure rates are 60, 65%.
In T cell, it will be ranging in 20, 30%, 40%. Go a little bit over.
Crux of all that I've seen is go a little bit overboard. Always have friendship with hematopathologist. It is the important thing in treatment of lymphoma. Okay, discuss with them, have a coffee with them, whatever. Until unless you don't have a good diagnostics in lymphoma, you won't be able to treat it. Otherwise, I told you, it's only three things: ABVD, CHOP, and R-CHOP. Your life is over in lymphomas. But if you want to have something special, you have the basic thing is hematopathology. When you don't see the last line, whenever we have a feeling, it happens to everyone. It happens to me also. अच्छा क्या है follicular lymphoma? अच्छा ठीक है, चलो फिर बात करेंगे. अच्छा क्या है DLBCL? अच्छा, I will see it. Something like that, but always keep your resident alive within you. You should not become a consultant or whatever, senior consultant or director. Bring that registrar's post, always keep it alive. It will help you. Why it is there, what are the markers were used, why only they have used 3 markers, why you not more. It is not correlating with my clinical symptoms. This is something which is not going on. The presentation is not, the morphology is not matching with my immunohistochemistry. These are very small point, but it is very important. So whenever you see a lymphoma, it's okay. Most of the cases will be straightforward. Lymphoma, moment it comes now, we will, lymphoma, we will treat. We over enthusiasm, we try to give them, okay, we will cure you. Don't worry. But if you see over a period of time, like DLBCL, the talks has been here, if you treat 100 lymphoma DLBCL patient, you will be only able to cure 50. Long term, in the first line, 50 are bound to relapse. So having a good rapport with them, either irrespective of IPI, I'm not saying IPI, low IPI, high IPI, irrespective, if you are treating 100, make sure it is 100 are going to relapse, 50 are going to relapse, not more than you will be treating in first go. So when you go into the clinical, so I'll tell you an example before I start, give me 2 minutes. So I have a patient who had a maxillary sinus swelling, biopsy taken, and was being given Hodgkin's lymphoma. Okay, treated not in India, it's an international patient. Patient is from Ethiopia, went to Thailand, and sometime down the line, his swelling restarting, growing again. So if you have someone reporting as a Hodgkin's, always have. Why Hodgkin's and maxillary sinus? Very rare. You can have, I'm not saying you cannot have, but always go through ask the hematopathologist to relook. If you are not happy, advise it from some other lab. It's not that I do not respect my hematopathologist. It's always that, okay, the way we are all clinicians, the people come to us for opinion and we give opinion based on the diagnosis. The same way, the hemat lab is also they are like another class of doctors who have their say, because if they are giving Hodgkin's, you are bound to treat the Hodgkin's way. But if little bit changes there, you are going, your whole treatment, your whole talk goes. So let's see what you can get. Most likely it will come as NKT cell lymphoma in the central one focal line, most likely. This is my clinical impression. Maybe I will be wrong. Maybe it was Hodgkin's only, because at 4 cycles of ABVD and the mass has started growing again. So this is, I'm saying, this is, and lymphoma, another which we say, lymphoma is a very stable type of disease. Nothing happens. It's an OPD treatment. No. Leukemias, sick leukemias, you will be easily salvaged, but the sick lymphomas are more difficult to treat. If you have a sick lymphoma, febrile, sick into tumor lysis, believe me, then you extranodal sites, it's a nightmare. So salvaging first month of lymphoma patients, if you are able to do, then it can become OPD level. But first month is very important. This is what I have learned over a period of time in last 10 years. Previously, it was like, okay, ABVD, CHOP and RCHOP. So I'll keep my topic a little short. And the classifications and all those things have been done by Young Brigade very nicely, done by Nihar and Fahimad. That's beautiful. So going to this first given was extranodal NK T-cell lymphoma. So we have got NK and T. So NK is natural killer T-cell lymphoma. Mostly when it comes to you, so one is nodal, one is extranodal. So my topic is extranodal. So either it is of NK origin or T. Rarely it is both. This is the point we should remember. It's not like both NK and T will be malignant. Either it will be NK or T, it will be malignant. Most commonly they are combined together. So either it is going to be NK predominant or T cell predominant. Rarely it can be both. So, and it accounts for less than 2% of lymphoma. So maybe you will be seeing 3 or 4 cases in a very good center, maybe 10 cases in a year. But once you see it, you always have something little different. Start thinking. So T cell, T develop from the transformation of natural killer cells or cytotoxic T cells are rare. So this lymphoma cell, mostly it's either of them. NK T cell is relatively more common in Asia or Latin America.
डबल लगा दो इसमें
unmuted, I think, online. Can you see the participants who is unmuted?
Okay. So more commonly in Asia, Latin America, but rare in Europe or North America. So then that's a problem because the diseases which I understood in last in my career, those diseases which are more common in those areas will have good drugs. Otherwise, will struggle. So anyway, it's in the extra nodal site, nasal cavity is the most common site. So we say nasal type extranodal NK T cell lymphoma. So why do we have this? As I said, why do we this NK T cell lymphoma had this geographic distribution? Why do we have like this is okay? Why Europe is not that common, or it's why it's in the Asian, in the Latin Americans. So they tried different ways. So Epstein-Barr virus universal. It's present all over the world uniformly, you can find. But strain 2 is something which is more confined to these parts. So when they tried to accumulate the data from this, so what they find is the 30 base pair deletion in Epstein-Barr virus LMP gene 1 C terminus region was common and associated with oncogenicity of Epstein-Barr virus. Association. And also the polymorphism, this HLA-DP1 single nucleotide polymorphism locus and immune response to EBV infections. So this one study came up with this theory, okay, that polymorphism we see in this type of patients. And so this is the basics. So EBV, strain 1 globally available, but strain 2 which is available, which is present in this part of the world. So are NK T cell lymphomas T or NK cell cancer or both? So most NK T cell originate in the NK cell with germline T cell receptors. NK cells expresses perforin, granzyme B, TR, CD2, cytoplasmic, and CD3 epsilon, CD56 expressed in most of the extra nodal NK T cell lymphoma, and T cell receptor protein is only expressed in T cell. NK T cell of NK cell origin have STAT3 DDX 3X mutation, whereas those of T cell origin have TP53 or okay, so this is good to know, good to learn, but one concept should be clear, that is of EBV originated, which strain, and there are some markers. So before, why these markers? You have been seeing the people talking on a lot of this positive. Is it possible to remember? Not possible. I will always look back. It's not. But one concept should be clear, that B cell lymphomas, you will have this positivity, CD10 positive, 20 positive. You gain those are there. In T cell lymphoma, generally you will say CD4 negative, CD8 negative, CD7. So the loss is more common in T cell lymphomas. So when it's not like what is positive in T cell lymphoma, what also is negative in those type, that classification is used. That is basic. So don't say, we have a tendency to see what are all positive in B cells. So that is okay in B cell, but T cell, you must also look for what is negative. That will help you differentiate which type of lymphomas it is. So as at present, you may have CHOP or CHOP etoposide based therapy or brentuximab vedotin coming in CD30 positive, but yes, over a period of time, we will develop or we will have something targeted. So we should keep all this in mind. Now, coming to the clinical features, the peak incidence is 40 to 50, male is to female 2:1, 70% are diagnosed in early stage. Why? Facial. Early, generally we diagnose this in the late stages. Why early? It's in the face. So most of the patient, whatever happens to the nose area, blockage, the most thing they will come early. That's the funda. That's nothing rocket science in it. So all the papers, almost all the papers in the Southeast from the Japan, China, Korea, you will have this presentations, the case series, you can say, whatever data we have is from these countries. And you can see nasal obstruction, bloody rhinorrhea, all these are present P symptoms almost equally involved. So involved tissue will be nasal cavity, hard palate, facial skin, pharynx, lymph nodes, skin in one, very rarely, but it's okay. Lung, liver, digestive tract, not that common, and the bone marrow, least common. So mostly you will have the early presentation getting treatment. But yes, in your practice also, you will see people coming at stage 1, stage or stage diagnosis. These are the other markers which is present in different types of different series. You can see CD3, 43, all these being positive. Now, is IPI the only way to diagnose? People have tried. This is most common IPI type of but if you have this from the Chinese Southwest Oncology Group, Asia lymphoma, that is CA, and this is the staging system which is more commonly used. How it is different? So in this, you have the lesions confined to the nasal cavity or nasopharynx. No local invasion, no lymph node. In stage 2, you have local invasion is present. Rest of the things remains the same. In stage 3 is the regional lymph node involvement, and the stage 4, you will have widespread disease. This is the way you go into this Chinese Southwest Oncology Group or Asia Lymphoma Study Group. Little different from IPA, which we should apply rather than going into the regular IPI based prognostic staging system. But people have done accordingly all the retrospective studies. They will try to do what is IPI. So this is KPI is the Korean prognostic index. Okay. Then came the PINC and the NRI. So these are the one who has been coming into the which drugs are being there, which is the one which is the high risk, which is the low risk, and of all, PINC is the one which has been more when you have the according to the low risk, no you can say no risk factors, and one it is intermediate, high when 2 or more than 2. So coming to the what is once you have diagnosed NK cell lymphoma and you have do the PET scan, you have done where it is involved according to the staging system, which where is it, early stage or the later stages or advanced stage. When you first decide, because therapy is different, outcome is different. So early stage, you may get away with radiation therapy. You may get away. I'm not saying you. So people have done. So the radiation, tried giving radiation. Radiation was the backbone. Still, it is one of the backbones of therapy. But people have tried making it with concurrent chemotherapy. So the chemotherapy, radiotherapy, chemotherapy, something like that. So in early stage, risk adapted for early stage NK cell where chemotherapy is given only in the person with adverse prognosis despite being low. So radiation, second, and the 3 DEVICs and the DEVIC protocol is the standard of care in Japan. So what we follow, the most of the doctors here will agree. So in early stage, DEVIC chemotherapy followed by radiation, or you start the radiation concurrent radiotherapy and again give 2 cycles, and this is the way. So whatever you have got is 78 to 70% of the overall survival, 2 and 5-year overall survival rate. So this is the standard of therapy. Now, this is what is the best for the advanced, you can say. This is the CCRT is the concurrent and the sequential is CSRT. So these are different chemotherapy models which has been used, and DAVIC, ISHAP, VIDP, VIDL. So asperginase-based therapy, they try to bring it and try to get it into the picture. Anthracycline, they are trying to get away from the anthracycline-based therapy, not much of use. And in the series of, you can say, advanced stage, SMILE therapy still holds the best. In the 1 year was 55% survival rate. And the adverse event was almost, you can see, anemia, pancytopenia, and the liver enzymes, mainly because of the methotrexate and the asparaginase. Now, NK T cell lymphoma, is there any role of transplant? So the people always try, I said, they always try to gain little bit. Whatever data you have, you will try to do something else. Okay, you become little emotional, treatment data. It may not be there. You try to go a little bit overboard. You get attached to your patients and you try to do something else. But try always to go back and see, is it what I'm doing? Is it correct? Like I was listening that. CHOP literally made difference, 55 to 75%. So little bit drug. So when you adding CHOP plus etoposide is making so much difference in the PTCL group. And you always say, okay, the prognosis is anyway poor, let's try something. So they tried consolidating, and consolidation, the therapy was for the auto transplant in NKT cells. So these are three paper in which they have different series which I compiled together. And pre-transplant response was CR or partial in the first group. And you can see 40% 3-year progression-free survival and 50. So almost 50, not going much more than that. Even if you go to the second paper, 30 to 40% range. Something not very good. So whether to do it, still a debatable. Based on this paper, you may select out your patients. You can talk to your patients. But recommended? No, still not recommended. But you can... I'm doing. I don't want you to relapse, or say, okay. So whether it will work, 20 to 30% data, not much. And this is also not randomized. This is just a series of patients. So there is something difference between RCT and case series. Case series can be biased. Most of the time it is biased. Okay, and one center, maybe multi-center study, they are pooling in the data because the percentage of patients being less, but still it has to be RCT, which we will try to. So another was, you have given chemotherapies, you have given the DAVIC protocol. Most of the patient will be doing well in the early stage, SMILE, not that 20, 30%, 40% at the max response are coming. So are we going, and when the relapses, are you going? So the drug which was wonder drug was this nowadays is the brentuximab vedotin, that CD30 being positive. To add it. You are trying to add it. You never know what is the outcome. You may be increasing the PFS, but overall survivals remains the same, not much difference. Okay, so still that is important. So the things which has been used here is pembrolizumab, ineffective. So the relapsed NKT cell lymphoma, this pembrolizumab has been used with quite a success. Single agent, or you add with anything else, it doesn't matter. The single agent, if you are the relapse cases, either it has relapsed after in the early stage or the late, pembrolizumab is the way to go in this. Also, if you have pembrolizumab being the costly, we talk in the conference, but when you talk to your patients, the 90% of the patient will be non-affording. It's very simple, very difficult. Keytruda you cannot give to each patient walking to your clinic. So you must have something. Maybe you may say they didn't have anything. So treatment, what is exactly what we know, this is all the Western world. What we practice is totally different. Okay, you must know, you should discuss with them, but when you are discussing, you may end up giving something like GDP or GCD, whatever. Okay, it may not be the standard, but you have to just progression, and you must tell them. When you say pembrolizumab, how many people will be affording? Even in the private institute, it's not easy to give someone pembrolizumab and go for LOSCT. Quite tough. So, but you must know that the pembrolizumab in the relapsed refractory cases, CD38 and CD30s are expressed in one half. Why specifically CD38 and CD30? Again, you have got a drug against that. CD38, you have got daratumab. So there are cases which has been reported that, okay, you have got daratumab, you may get some response out of it. it's indicated in multiple myeloma. Now the T cell ALL are reporting it the upfront. Now you are coming into the T cell where CD38 is positive. You may use it and you can consolidate. If you have got some kind of remission, you will get it into this. CD30, we have talked a lot in almost all the presentation. Autologous cytotoxic T cell, yes, we'll be happy if someone can get us this, and they have got some response. So this is the different patients you can see the on the right side of the corner, nivolumab, and lot this, but this is yet to be proven that it can be used in regular routine practice. So now coming to angioimmunoblastic T cell lymphoma, again, AITL represents only 1 to 2% of the cases of NHL, but nearly 1 to 5 cases of PTCL diagnosed, and of every 5 cases. So almost in PTCL, now PTCL is a dustbin diagnosis. When you cannot diagnose any particular, then most of the pathologists will label it as PTCL-NOS. So they will try doing, okay, this is AITL, or at the end, it's not like PTCL is the first line diagnosis. It's that when they have taken out all the diagnosis, I think so. They will try to get it. It's not fitting into any, it's PTCL-NOS. So then with your markers, gene array that going into different type, it may be useful in long run. So advanced age individuals, generally middle age of 65 years without gender predisposition, you can say fairly distributed, 16% in US in one paper quoted, 18% in Asia, and 20% of all the lymphomas, T cell lymphomas. So EBV is effective, affects the B cell, but spare the malignant T cells. So Epstein-Barr say here, NK cell, and it was affecting the T cell. Here it affects, but it affects the B cell. It spares the T malignant cells. That's you should remember. The cell of origin is follicular T helper cells and the affected T cell subset. IHC, you can have all this positivity depending CD4, 5, 2 positive for T, follicular helper cell 10, and the CXCL30. This is one of the NICOs, quite common. In 50% of the cases, you will find this being positive, BCL6 and PD1. CD30 again expression is common. Again, why? Again, you can understand why CD30 expression is being specifically said. So you have a drug which you can use. And the chromosomal abnormality mainly 3 and 5, and in 21 you can find this abnormality. What it will render, maybe in future we can have something coming out of it. Clinical features. Now, one of the weirdest lymphomas to treat is angioimmunoblastic T cell lymphoma, which will have varied variety of presentation. So you can get call for anything. You may be getting a call for polyclonal gammopathy. On evaluation, you may end up treating as lymphoma. So never say that people and elderlies, when you find, okay, it's monoclonal, MGUS, nothing else. Always think, try to take the history. Very important. So try to take how long he has been problematic, what has been going on, because it doesn't present just with these symptoms, like, okay, nodal presentation. But one of the weirdest lymphomas to be dealt with is angioimmunoblastic. So you can have positive rheumatoid factor, positive anti-smooth muscles, coagglutinates. It can present with anyone's. So whenever you have, always keep in mind the patient has been sick for a long time, is showing MGUS, something else is there. And you may turn out in diagnosing AIT a little bit early. So you can right side you can see this B symptoms being present, LDH elevated and advanced. Not going into too much of detail. You have got skin presentation in almost 30 to 40% of the cases. Your skin involvement will be there. DCT being coming positive, hypereosinophilia. So you have to catch up all this add-on. You may have all the features. You may have some features, but when you add things, when you see on the consults, you should be pointing towards that. So keep in the back of the mind that, okay, angioimmunoblastic. Sometimes you will get a straightforward lab gives you straightforward patient comes, but sometimes when you go for a consult, always have this in mind. Now, in prognostic, there are a lot of prognostic models. So IPI is there, for PTCL is there, AITL is there. So all of them have scored scoring patterns is there based on the age, performance status, extranodal sites, B symptoms, platelet count, and whatever they have tried to. What is the use? Low risk, intermediate, or high risks. Trying to finally consolidate which patients are more curable, which patients needs more aggressive therapy. The whole fund of doing all this is which you can get away with the lesser therapy. And you can see the 5-year survival rate in the range of 50%, not more than 40 to 50%.
No, friend, when you have this, we have discussed. We have discussed all these therapies. We have been CHOP being given, CHOP plus etoposide being given, BV plus CHP being given, especially with the CD30 positive cases, and involved site radiation can be given. After 4 cycles of therapy, you are giving reassessing whether it's there or not. If CRPR, you complete 6 cycles, do the PET scan again, CR. In low risk, just continue. High risk, counsel for autologous stem cell transplant. In high risk cases, especially when you have the high risk features, when the patient is fit, always go for it. Again, I'm saying there is no randomized. It will be case series which is giving you all these things. So you're going a little bit extra on the consolidative frame, be it PTCL or be it ALK negative ALCL or be it angioimmunoblastic lymphoma. This you are going to treat it a little bit. You think that it's when you end up, so you never know whether it is beneficial or it is harmful for the patient. So after 4 cycle, if it is progressive or no response, you have to go for the salvage regimen, and finally you have to tell the poor prognosis and go for the LOSCT. Early infant, you can see the low dose.
There's 3 minutes.
Sure. So this is the outcomes of the CHOP. Again, you have got 40 to 50%, whichever have. There are case reports of different drug extra, you can say, of which brentuximab vedotin is the most commonly used, 57% PFS to 76% of overall survival. But other drugs which have been used is alemtuzumab, Zumab, romidepsin, cherdamide. So not much of thing, but these are things which has been used. In relapsed AITL, you must do re-biopsy to rule out EBV-related DLBCL. That is the must. Relapse anyway. So what is in your mind, you should be taking into account. Then you should go, what is it, the transplant eligible, transplant ineligible. You have your fixed course, then you have whichever drugs you are going for that based on your markers. And transplant eligible, yes, whether you can counsel for autocity, but in relapse setting, auto doesn't show anything. Once it is relapse refractory, always go for LOSCT. So the case series will be there for going for LOSCT. More commonly used being common in lymphomas, and we don't do here in our setting. In the different institute have different finding, but you should be going because of the paucity of the cases. And these are the one you can see the LOSCT in which CIBMTI data 3 years progression free survival of was almost 41%. So this is different registries are going in favor of allogenic transplant rather than autologous transplant. So the active agents, again, we have seen in all other, they have been tried. Different drugs have been tried, hit and trial. You just try and giving, but 5-azacitidine is the one which is good, which is available with. Another is bendamustine, which is quite locally available, and lenalidomide. These things you can try in your practice and try to salvage those who are transplant eligible, sick patients, and have an options. Never say no to them. At least some hope should be given to each and every patient, which I believe. With this, I will end my talk. Thank you for your attention.